Good day, dear great surgeons. Can you hear me? Today, our session will be about the beloved chapter, Pediatrics. The pediatric chapter is very important chapter in the exam, and there is no MRCS exam without the pediatric chapter because it's already overlapping with all chapters of the surgery, starting from anatomy, physiology, pathology, with all the subspecialty of the surgical specialties from trauma, even neurosurgery and GIT, even endocrine, all chapters are pediatrics. All the pathology of the adults will be studied in pediatrics. So it's very important and it's really important. And the congenital anomaly overlapping with the embryology chapter. That's why in the embryology chapter, you found only 8 pure questions in the whole bank of the anatomy. But in the exam, it's not the 8 question, but it's the overlapping question with the pediatric in the urology and pediatric chapter. And together we can. So let's crack the chapter together. So let's have a very simple, happy question as a start. Regarding the omphalocele, what is false? What is the omphalocele, by the way? Anyone familiar with the omphalocele? That's how you read any question. It's a defect in the abdominal wall. But the omphalocele is different from the gastrocases that the omphalocele has and the gastrocases doesn't has. What is the difference between the omphalocele and the gastrocases? Anyone here? The peritoneal sac. That's great. You can talk and make this meeting productive. So this photo will be shown. Is it omphalocele or gastrocases? Taking too long to load. Now, hope the photo appeared. From this photo, you found this baby have omphalocele or gastrocases. Yes, as long as we have the peritoneal layer, so it's omphalocele. So what is the gastrocases? Gastrocases is when we don't have the peritoneal layer, and then we will have to do a temporary coverage until a definitive coverage be done. And in the past, gastrocases was very high mortality, but now it can be done. So gastrocases is isolated abnormality where the bowel lies outside the abdominal wall through a defect located to the right of the umbilicus without any peritoneal sac, while the exomphalus, which is type of omphalocele, where the liver and gut remain covered with a membranous sac connected to the umbilical cord and associated with other abdominal and developmental defect. So yes, the herniated organs lie outside the peritoneal sac is not true regarding the omphalocele. It will be gastrocases if it's outside the peritoneal sac. So this was our happy question. Let's have another question. And we said it's about pediatrics. Thank you, Dr. Langdon. You answered it correctly. The photo is about the gastric cases. So let's have this question together. A one-day-old baby girl noted to become profoundly cyanotic while feeding and crying. What is this? Of course, it will be transposition of the great arteries. So it's important to be aware of the common congenital cardiac anomalies, and the main differentiating factor is whether the patient is cyanotic or acyanotic. And here you have to be aware what is common. The most common at birth cyanotic is the TGA, transposition of the great arteries, but the followed is most common overall. But at birth, the transposition of the great arteries is the most common at birth cyanotic disease, while acyanotic, like the BSD, is the most common cause. Clear? Those are direct questions that might come in the exam. Can a baby boy who is 4 years old have an anal fissure? Yes or no? So let's have this scenario. A 4-year-old baby brought you to the clinic. He gives a history of difficult, painful defecation with bright red rectal bleeding. What is the most likely diagnosis? Of course, when you hear red rectal, you're towards what? It's an anal fissure. It's not the other one. How about if it was a red current gel stool?
Interception.
That's great. And it will be not just painful defecation, it will be painful abdomen, right? Thank you. This is the pediatrics. It's not hard after all, right? You are all great. Let's have another happy question. A 2-week-old baby referred to your surgical team by pediatricians, and they are concerned because the child has a painful area of macerated tissue at the site of umbilicus. On examination, a clear yellow fluid draining from the umbilicus when the baby cries. What is the diagnosis? It,
Persistent vital intestinal duct.
again,
Persistent vital intestinal duct, mucus diverticulum.
why it's not a patent urachus?
Sorry, I didn't get that.
Here we have a urinary discharge. This indicates a patent urachus.
Oh, yeah, patent uricus, sorry. Yellow discharge, I thought it might be stool.
If he telling you about stool, he will tell you about the odor, and it will not be only yellow, it will be fecal matter. So this will be then a persistent intestinal duct. And yes, it might be a cause for Meckel's diverticulum as well. But here, it's a clear umbilical urinary discharge. It's about patent arcs or urachus. So happy with
Okay,
your
thank you.
differential and your mode of thinking. So if we have a reddish umbilicus that bleed on touch, what could it be in an infant? If we have a cherry red lesion in the umbilicus that might bleed on touch, what could it be? Umbilical granuloma, for example? Any cherry red lesion that bleeds in touch, it's a granuloma. And here, regarding the umbilicus, it will be umbilical granuloma. So if he told you in the exam about a cherry red lesion that bleeds on touch, it will be umbilical granuloma. And how would you manage it? How would you like to manage this umbilical granuloma? Surgical excision of this umbilicus?
Excision of the granuloma.
How about a more simple procedure like topically applied silver nitrate?
Okay.
Keep the surgery in pediatrics the last option unless it's a life-saving. For example, the diaphragmatic hernia. Is it emergency or urgency to repair? It's an urgency, not emergency. You have to resuscitate the patient and the pediatric patient who you have diagnosed with diaphragmatic hernia. And after resuscitation and preparing this patient, you can then do a repair for this diaphragmatic hernia. Okay? And the same technique for the umbilical granuloma. You do a silver nitrate applied, then if it's not responding to the silver nitrate, you can do surgical excision and of course pathological assessment. Clear? Okay. Thank you, Dr. Aisha. And now, what is the commonest abdominal emergency in children below 1 year age? Is it appendicitis or intussusception or intestinal malrotation or pyloric cirrhosis or midgut volvulus? What is the most common abdominal emergency in a child below 1 year age? Below 1 year age. Commonest emergency, not urgency. Hernia is urgent, not emergent. Thank you, Dr. Bharat Hormone. Intussusception. Intussusception is the most common emergency below 1 year age. In pediatrics, it's all about the timing. It's all about the timing. Like the transposition of the great arteries is the most common in 1 year, in 1 day, in the first day, while the phalloc is the most common cyanotic in all. So I thought it would be more fun to have pediatrics with you today. Is it a hard topic? Okay. So let's have a direct, happy question. If you have a malrotation, how would you manage it surgically? What is the name of the operation?
Let's procedure, sir.
So happy to hear your voice. Yes, it's LADS procedure. And in the exam, he will give you a long scenario just like this one, asking about the same idea you already know about the LADS procedure. He will tell you a long scenario about a female unit who is born at term and has an episode of bilious vomiting. What is meant by bilious vomiting? What does it mean to have a bilious vomiting?
So bile stain vomiting,
That's great. And what is the color of the bile?
greenish.
That's great. It's a nightmare for the general surgeon after doing cholecystectomy to have a drain filled with a green bile, right?
Yes, sir.
May God save us all from this complication. So, if you have this village vomiting in a newborn who is born in term, you have to think of this is intestinal malrotation with volvulus, and they will be treated by Ladd's procedure. What is Kasai procedure for?
It's a Kasai procedure for biliary atresia.
That's great.
Port to vaginistomy. Roy and Y port to vaginistomy is done here.
Such a great surgeon you are. Thank you, Dr. Aisha. How about the Ramstad pyloromyotomy? What it's for?
Sir, it is for pyloric stenosis, congenital hypertrophic pyloric stenosis.
For the-
Here,
Yeah.
circular muscles are cut.
Yes, it's for the ships. Congenital hypertrophic pyloric stenosis is treated by Ramstad pyloromyotomy. And how would be the congenital hypertrophic pyloric stenosis be presented?
Non-violent.
Projections of non-bilious vomiting.
With will it be bilious or non-bilious? Non-bilious. So that's great. Do you know what is the pyloromyotomy? This is the pyloromyotomy. I'll share it with you. And by now, it can be done either surgical or endoscopically, by the way. You know this? I will share it as well. I like effortless projectile non-bilious vomiting. Thank you, Dr. Saprona Nova. Clear. I don't want to get hard on you. You seem just refreshing. So we'll keep the question as much as possible be direct. Okay, okay. We have a unit noted to have a bowel obstruction. What is the most likely cause? In neonate.
Meconium plaque, sir.
That's a great. And what is the most common cause for meconium plaque in neonates?
Sir, cystic fibrosis.
Amazing cystic fibrosis. How would you investigate for cystic fibrosis?
It's a sweat test.
Chloride sweat test. Chloride sweat test. Yes. Those are the questions that come in the exam, just in a long scenario. So don't be confused by any long scenarios. You can do it always. So the meconium ileus, usually delayed passage of meconium in abdominal distension, and most probably can come with the polyhydramnios in a diabetic mother, by the way. And the majority of them have cystic fibrosis, and the X-ray may not show any fluid level, as the meconium is viscid depending upon the feeding. And you will find the PR contrast study may dislodge the meconium as a solution. So the investigation will be the solution and be therapeutic, not just diagnostic. This reminds me of the intussusception with a uh, pneumatic compression. You can do either investigation and as well as therapeutic. And in investigation, do not respond to the PR contrast and in a style cysteine will require surgery to remove the plug of the meconium areas. And always remember, it will require chloride Swiss cyst to investigate it. So we remember that the Kasai operation is for,
Biliary atresia.
and biliary atresia can be diagnosed for a jaundice that have been persisting for more than how many days? How many days will be suspicion for a pathological jaundice?
More than 14 days.
14 days.
Exactly, you are all great. More than 14 days are enough to make this patient be suspicious for you. And will be the problem in the conjugated or the unconjugated bilirubin?
Conjugated bilirubin.
Conjugated bilirubin, because it will be indicating an obstructive jaundice, right?
Obstructive jaundice. Yes.
So it is the same in adults as well. In the adults, when you are diagnosing obstructive jaundice, it will be the problem regarding conjugated or unconjugated.
Conjugated bilirubin.
The problem in the direct bilirubin or the indirect bilirubin. You know the conjugated. Conjugated is the direct. Okay?
Yes, sir.
Is the direct. So when you ask for the labs, you ask for the total bilirubin as well as the direct. And by subtracting the direct from the total, you will get the indirect. And you will get panic for this patient if you found the direct, which is the conjugated bilirubin. Okay? You have to be familiar with the both terms, the direct and the conjugated as well. So the direct bilirubin is the same as the conjugated bilirubin. Okay?
Yes, sir.
If you found a preterm baby came to you with abdominal distension and blood stool, what is the most probable diagnosis? Again, preterm baby with abdominal
Sir, necrotizing enterocolitis.
necrotizing enterocolitis. That's great. And if you do an X-ray, you find what sign?
Sir, air in the gut and the distended bowel.
Okay, it can be called pneumatosis intestinal.
Yes, sir.
Intestinal. Pneumatosis. Pneuma means air. Intestinal, intestine. So pneumatosis intestinal means air in the intestine. Okay,
Yes, sir.
just like this picture. Let's have one distended abdomen of a preterm baby. And the mainstay in necrotizing enterocolitis will be surgical treatment, the main management.
Sir, we do mainly conservative management.
Amazing.
And if it deteriorates, then we go for surgical management.
So in surgery, we have to learn that not every emergency is to do surgery. So necrotizing enterocolitis must be suspected and be in term in our mind not to do surgery, but to do gut rest and total parenteral nutrition. And unless there is a perforation, then you can do laboratory.
Yes, sir.
It's not all about surgical intervention. It's about managing the emergency. Just like pancreatitis. We are studying pancreatitis in order not to open this abdomen. Let's have a pure memorization question. Okay. Okay. This is a pure memorization question. Medicine is all about understanding the medical condition, but some are incidence questions. Like this question, he is asking you about the concern of the mother, which is asking you about the foreskin retraction. So by the age of 16-year-old, almost all the foreskin of the benign tissue will be retractile, around 95% of all the foreskin. So if you have inflammation in the gland penis, this will be called balanitis.
Balanitis.
Yes.
How about inflammation of the foreskin or the penis? It's called bothitis. Bothitis. So balanitis is the glands, and bothitis is the foreskin. How about a prolonged retraction of the foreskin, which is a mother presented to us with in our clinic in the last question? Again, he is having the prolonged retraction of the foreskin around the glands and edema occur. What is this?
Genetic obliterance, sir.
How about paraphimosis? Are you familiar with paraphimosis? Paraphimosis is prolonged retraction of the foreskin proximal to the glands and may allow edema to occur. And this may then make the foreskin manipulation difficult. And if this presents and persists, this will require circumcision because this will cause phimosis. So the paraphimosis is the stage before the phimosis. And phimosis is where you require a surgical emergency circumcision. Circumcision is regarding religion, is regarding habits of cultural beliefs, but here you will require circumcision as an emergency in the phimosis patient. He will have inability to retract the foreskin and might be partial or complete. Take care.
Okay, sir.
In our countries, circumcision is very familiar to be cultural belief, especially in the Muslims and the Jews. And in Egypt, we are Egyptian Jew circumcisions all. So you have to be familiar with this operation. In UK, they are not familiar with cultural circumcision, but they have to ask you, do you know when to do emergency circumcision? This is a condition. It's called phimosis. I'll try to give you an image so you never forget it. I hope this makes it understandable. So this is a paraphimosis and phimosis. Clear? So let's change topic and get some. I like this upcoming question. It's a very recurrent question in the exam and came in my exam. Even if they changed your question bank, they will have the same scope. So a 2-year-old baby with a history of rectal bleeding. The parent noticed that post-defecation a cherry red lesion is present at the anal purge. What is the most likely diagnosis? Hemorrhoids is not very common to be found in children,
Junior polyp.
just a juvenile polyp. Amazing. You are such a great surgeon, Dr. Arya. Thank you. So Those lesions are usually hamartomas. Those lesions are usually hamartomas. What is meant by hamartoma? It's not malignant at all. Just like ampuloposis. But the children might have a fissure, right?
Yes, sir.
But this is not a fissure because a fissure means a wound. He is
It
feeling
will be painful if it's fissure.
exactly. So if he told you about there is no lesion, it will be most probably with defecation, anal fissure more probably, but juvenile polyp because there is a lesion already present at the anal verge. If he was an adult, we would think of hemorrhoids, right?
Yes, sir.
Happy question until now?
No, sir.
They are hard, so. Okay, let's have this happy question. We just talked about this scenario. We'll make it just long like the exam. A male implant born spontaneous vaginal delivery at 39 weeks gestation. So he is there. He is well after the birth, established one bottle feeding and discharged home. His parents are concerned because he subsequently become unwell and vomits a large quantity of bile-stained vomit. I like those parents who tell you bile-stained vomit. They will tell you like greenish or yellowish. Anyway, and 2 days after discharge home, on examination, he looks ill and abdomen soft but not distended. What is the most likely cause? Our key here is a bile stain in the early days, right?
Yes, sir.
So it will be duodenal atresia or anal atresia or bilocus stenosis or diaphragmatic hernia or intestinal malrotation with volvulus that requires LADS operation.
Malrotation and volvulus.
And will require LADS operation, right?
Yes, sir.
So you are such a great surgeon. How about the meconium ileus? It will be presenting with distended abdomen and the most common to be with what disease? Cystic fibrosis, sweat chloride.
Cystic fibrosis.
So not meconium ileus. And the baby didn't pass in stool unless you have put your finger in the anal verge. What could it be? It could be Hirschsprung disease, Hirschsprung disease, or else. So you memorized the question, but you didn't memorize the understanding concept of the question, or I'm getting it. So delayed passage of meconium is suggestive of Hirschsprung disease, and the investigation of a choice will be full thickness rectal biopsy. And by the way, the Hirschsprung disease reminds me of the achilles of the cardia in the adults. This is in the esophagus, and this is in the anus. But it's all about
Absent of ganglions.
exactly. And in Hirschsprung, the absence of the ganglia will be in the collapsed part or the distended part.
Collapse part.
Collapse part. Contracted part.
Great. In the achalasia of the cardia, the absence of ganglia will be in the collapsed part or the distended part?
Distended part.
Exactly. That's why I like those topics to be studied together. So, can the Hirschsprung disease be diagnosed without a rectal biopsy?
Full thickness rectal biopsy.
A full thickness rectal biopsy is a must to diagnose a Hirschsprung disease. And the baby will come to you without any defecation until you put your little finger in his anus and a gush of stool will come out. And this is the difference from meconium ileus. Meconium ileus will not get any stool like the Hirschsprung disease. The Hirschsprung disease, with your release of your finger from the baby anus, it will get you stool, a gush of stool. But in meconium ileus, the baby will distend it and require flushing. Clear? It will
Yes,
require
sir.
decompression. So, have another habit question. A very common situation in the ER of the babies, and very common question in the exam I have. Your old baby inhales a peanut and arrives to the emergency. What to be done? If the patient is cyanotic, require immediate removal, and this is undertaken in fully staffed theater. Ideally, a rigid bronchoscopy should be performed. So arrange immediate transfer to theater and do a bronchoscopy. This patient is cyanosed. And very common question in the exam to ask you where this peanut be lodged, the left or the right main bronchus. What is your opinion?
Right main bronchus. Right bronchus is shorter, wider, and straighter. That's why it may be lodged in the right bronchus.
That's great. You are totally correct, Dr. Thank you. And this is very common question in the exam, and I believe you have faced this question already, right?
Yes, sir.
So let's have another habit question. We talked about it regarding the pediatrics. A 7-year-old girl presented with vomiting and diarrhea. She is crying and drawing her legs up and sausage shape.
Intussusception.
Susception.
Right. Require no further investigation. It's in interception already. What would you do for the interception? How would you manage an interception girl? Surgical? Would you do a laparotomy? We have two situations in interception: ileoileal or ileocolic, which will require surgical intervention and which will require a trial with pneumatic reduction.
Ileoileal, we require surgery.
Exactly, Dr. Ibad. Thank you, Ibad. You paid off for this Ibad. Deserve it.
Ileocolic, we need pneumatic trial.
That's great. Thank you, Dr. Ibad. So,
You're welcome.
so it's a very common question and it's a very common emergency and the very commonest emergency in children.